You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for October 22nd, 2021. This week, aspirin, induced hypothermia, half-dose DOAC, and social media. First up, a brief note on COVID. It continues to get better. In the U.S., cases, hospitalizations, and deaths are trending down, and that is good. I've decided to stop tweeting and discussing COVID-19. As someone who had enjoyed critical thinking, I had thought the pandemic was a great canvas for rational thinking, kind of like a mountain pass is great for bike training. But the polarization is just too much. When you can lose friends or a career over an interpretation of data points, Pragmatic John says it's time to wait it out. I do not know, but I hope that the combination of natural immunity and vaccination will keep cases down, and then normality can return. We can go back to arguing about PCI and stable coronary disease. Now, speaking of normality, I traveled to Barcelona, Spain last week to participate as faculty in the European Association of Cardiothoracic meeting. I want to thank the EACTS leadership for the invite. After nearly 2 years of Zoom, it was incredibly nice to meet colleagues in real life, and it was a true honor to be invited to give a neutral Martian's view of the recent trials. And also, thanks to Professor Richard Whitlock for helping me set up my Garmin watch. It took a heart surgeon from Canada to help me fix my watch. First topic today is aspirin. I want to talk about aspirin for primary prevention, which made news recently when the USPSTF posted a draft statement that people aged 40 to 59 should decide with their clinician whether to start taking aspirin, and people older than 60 should not start taking aspirin, again, for primary prevention. This led to the New York Times to have coverage with a headline, quote, aspirin use to prevent first heart attack or stroke should be curtailed, U.S. panel says. And many print and TV outlets covered it, and actually a handful of patients asked me about the aspirin news. But what's weird about this story is that most of the new data was published in 2018. 2018, now in pandemic time, 3 years ago, was a totally different era. I'm a huge fan of the USPSTF, the United States Preventive Services Task Force, because they get as close as possible to a neutral Martian view of the evidence. And as part of their new recommendations, they also published a draft of a systematic review and meta-analysis of the primary prevention aspirin data. But I think we should revisit the 2018 big trials, which This Week in Cardiology covered at the time. There are 3 trials, and they all begin with A. First is the ARRIVE trial. First author, Gaziano. Paper was published in Lancet, 12,000 patients, mean age 64, 5-year follow-up. And get this, the mean ACC 10-year risk was 17%. So these were high-risk patients, at least using the cohort equation. The primary endpoint was MACE, and it was only a 4% reduction with aspirin. Hazard ratio 0.96, not statistically significant. However, there was a doubling of the GI bleeding rate. 2.11 was the hazard ratio. The authors noted that despite a 17% 10-year risk of events, the actual event rates in this trial were as low as 4%. So the authors felt that despite trying to enroll a high-risk adult population, they actually enrolled a lower-risk group. Now, my take was that in this group, aspirin had no significant effect on cardiovascular prevention, but doubled the risk of GI bleeding. All right, second trial also begins with A, the Ascend trial. First author, Jane Armitage, New England Journal of Medicine, 15,000 patients, mean age 63, and 7 years of follow-up. The primary outcome was a MACE, and again, this was a 12% relative risk reduction in events with aspirin that made statistical significance. However, major bleeding was a 29% increase that also met statistical significance. So the take-home is that aspirin prevented serious vascular events, but it also caused major bleeding events. The absolute benefits were largely countered by the bleeding hazard. In my take, the diabetics had a higher event rate, and while the CV event rate was lower with aspirin, it was non-fatal events which drove the reduction. Vascular death in this trial was no different. The reduction in non-fatal events was countered by a greater increase in major bleeding. Okay, the third aspirin trial also begins with A, the Esprit trial. This was one trial but two papers, both published in New England. The first was the effect of aspirin on all-cause mortality in the healthy elderly. The second was the effect of aspirin on CV events and bleeding in the healthy elderly. The first author was McNeil, New England Journal of Medicine, 19,000 patients. These were older patients, 74 years, and had almost 5 years of follow-up. In the MACE endpoint, the primary efficacy endpoint, the hazard ratio was only 5% reduction, 0.95, which was not statistically significant. Major bleeding, however, was 38% higher with aspirin. That was statistically significant. And I think the most important signal is overall death. Here, 5.9% versus 5.2%, and that 0.7 absolute risk increase in the aspirin group had a hazard ratio of 1.14 that did meet statistical significance. So that had an upper bound of 29% higher rate of death in older patients. Now, the higher death rate may have looked to be driven by cancer-related deaths, but still, death is a pretty bias-free endpoint. And the author's conclusion was that aspirin as primary prevention in older adults resulted in a significantly higher rate of major bleeding, did not result in significantly lower cardiac events, and in the separate paper, higher all-cause death was observed among healthy older patients who received aspirin. The next aspirin paper was the USPSTF's systematic review, which is available online. And then for cardiovascular events, they included 13 clinical trials. Major cardiovascular events, the hazard ratio was 0.89, so an 11% reduction, and that was statistically significant. For cardiovascular death, the hazard ratio was 0.95. That did not meet statistical significance. For major bleeds, it was a 45% increase that did meet statistical significance. And all-cause death, no statistical significant difference. Now, when I tweeted out that this was all old news, dating back to 2018, trial expert Sanjay Kaul from Cedars-Sinai responded to me that the evidence against aspirin use in primary prevention was even older than 2018. Kaul sent me a link to an FDA report from 2014, and I'll link to that in the transcript. That said, the FDA has reviewed the available data and does not believe the evidence supports the general use of aspirin for primary prevention of heart attack or stroke. In fact, they wrote, there are serious risks associated with the use of aspirin, including increased risk of bleeding in the stomach and brain in situations where the benefit of aspirin for primary prevention has not been established. Well, the FDA may have felt that way in 2014, but obviously there was enough equipoise to do these three major trials at the time. Now, my colleague, Dr. Melissa Walton-Shorley, wrote an editorial on the Heart.org Medscape Cardiology on aspirin and had two themes. One was that patients with a high calcium score may still benefit from aspirin for primary prevention. And her second point was that the major network coverage may have led many patients to stop taking aspirin without consulting with their clinicians. As always, it's a great piece. My take-homes are that Dr. Walton-Shorley is correct. This news applies only to primary prevention. Patients taking aspirin after a vascular stroke or MI or PCI should stay on antiplatelets, and we have to be very careful with that messaging. The second take-home is it's clear that aspirin reduces CV events by about 10%, but this translates to a very small absolute risk reduction, so small that it is not enough to reduce cardiovascular death or overall death. The third incredibly clear point is that aspirin increases the risk of major bleeding by a greater amount than it reduces non-fatal cardiovascular events. Yet this risk is also small in absolute terms. And the signal of a 14% increased risk of death in healthy elderly in the ESPRIT trial is worrisome. I mean, keep in mind that the upper bound of that hazard ratio is 1.29. Finally, the contemporary studies are very strong. I put more weight on the 2018 studies because they studied patients in the era with modern background therapy. And each of these trials accrued many events and gave similar signals. Now, as for saying that having a high calcium score will confer a high enough risk that aspirin may benefit, I think it's plausible, but highly speculative. Remember, the 10-year risk of a cardiovascular event in the ARRIVE trial was 17%, way above the statin threshold of 7.5%. And that study found no compelling net benefit, a mere 4% relative risk reduction. And neither did ASCEND or ESPRIT find any significant net benefit. Well, I suspect that whether or not calcium produces a heterogeneous treatment effect of aspirin might be gleaned from the data. I may be wrong here and trialists can correct me, but let's say the authors of these trials pooled their data and studied those who had high calcium scores. You might get a sense of a signal, a subgroup signal. But of course, that would be a post hoc test and it would be susceptible to the play of chance. I mean, never forget that one's horoscope sign produced a spurious signals from aspirin in the ISIS-2 trial. But Dr. Walton surely is correct in saying that if a patient with a high calcium score and low bleeding score wanted to take aspirin after a discussion with his or her doc, then that is fine. As we always discuss on This Week in Cardiology, each story has a specific and a larger lesson. The specific lesson of aspirin is that the net benefits in those who have yet to have an event, primary prevention, is dubious. The larger lesson, though, is that it is super hard for preventive therapies to substantially improve health in those without disease. We clinicians are at our best when we treat those who seek our help because they are sick. Due to unintended consequences, here, major bleeding, preventive therapies have a much harder time delivering a net good for people without disease. All right, next topic, cooling for cardiac arrest. Now, I know this topic doesn't bring the clicks and attention that anticoagulants do, but I love it because it teaches larger lessons about the sclerosis of evidence translation and the power of randomized controlled trials. JAMA has published yet another trial looking at induced hypothermia in survivors of out-of-hospital cardiac arrest. The trial is called the Capital Chill Trial. Now, before I tell you the results of this comparison of a target temperature of 31 degrees versus 33 degrees in survivors of cardiac arrest, let me tell you the results of recent trials of induced hypothermia, and then you might be able to guess the results of Capital Chill. In 2013, the TTM trial compared 33 degrees to 36 degrees in post-cardiac arrest survivors in about 1,000 patients, and there were no differences in death or neurologic function, plus the cooling arm had more adverse events. Well, that wasn't enough to change practice. 7 years later, in 2021, the TTM2 trial compared 33 degrees to normal thermia in almost 2,000 patients, and the results were similar, no difference in death or neurologic outcomes. And again, there were more arrhythmias, greater use of paralytics, and longer time on the ventilator in the cooling arm. New England Journal published both the TTM trials. They clearly established that 33 degrees is no better, probably worse than just keeping normal temperatures. Now to the Capital Chill trial, which tested 31 versus 34 degrees in almost 400 patients. Well, already, if 33 degrees was no better than normal temperatures, what do you think 31 degrees will do? You guessed it, no difference in the primary endpoint of mortality or poor neurologic outcome. In fact, 48% had a primary endpoint in the 31-degree arm versus 45% in the 34-degree arm. My friends, I think we can now say there is no longer equipoise for induced hypothermia. Cooling survivors of cardiac arrest simply does not produce better outcomes. The larger lesson, though, is that even though cooling makes sense, the evidence shows it does not help. Since it requires more effort, more nursing attention, and TTM clearly had higher adverse events, we should de-adopt this strategy. You could argue it should have been de-adopted in 2013 after the first TTM trial. Once again, the randomized controlled trial shows its power to inform us how best to care for patients. We mustn't ever be scared to test our favorite strategies in the randomized controlled trial. Half-dose DOAC therapies. Now, the group led by Dr. Andrea and Natali have long provided us with important information regarding anticoagulation after EP procedures. I remember when I started ablating AFib nearly 20 years ago. It was the Natali group that first recommended uninterrupted warfarin. This was provocative, it was early, and it was correct. This month, the journal JACC Interventions has published a study looking at a novel strategy to prevent device-related clots after Watchman implantation from the same research group. This was a non-randomized study enrolling consecutive patients who had had Watchman at 3 centers over a 5-year period early in the Watchman experience, from 2014 to 2019. The 2 strategies tested were, the first one, standard antithrombotic therapy, and this is a NOAC plus aspirin for the first 45 days, then aspirin plus clopidogrel for half a year, 180 days, then aspirin after that. The active treatment arm was half-dose DOAC plus aspirin for 45 days, then half-dose DOAC thereafter. Now, crucially, the choice of these 2 strategies were at the discretion of the clinician. That's a huge point, one that I will come back to. And the primary efficacy endpoint was a composite of both safety and efficacy endpoints. For instance, thromboembolic events like ischemic stroke, TIA, and peripheral systemic thromboembolism, a device-related thrombus, and major bleeding. And the results strongly favored the half-dose DOAC group. After a median follow-up of about 13 months, device-related thrombus occurred in 3.4% of the standard treatment arm versus 0% in the half-dose DOAC arm. The risk of non-procedural major bleeding was 0.5% versus 3.9% in the half-dose DOAC versus standard, and the rate of the primary composite endpoint of DRT and thromboembolism and major bleeding was 9.5% in the standard antithrombotic arm versus 1% in the half-dose DOAC, and the hazard ratio is nearly 10. So the authors conclude that clearly half-dose DOAC is the better strategy. They also acknowledged that the main limitation of the study was the non-randomized choice of strategy. Now, although the baseline characteristics of 2 groups did not reveal any major differences, regular listeners of This Week in Cardiology know that many factors determine how a clinician chooses a therapy. Some of these factors come out in a spreadsheet, but many of the intangible factors do not. And this is why randomization is so important, because it balances all the important covariates, those that go on a spreadsheet and those that do not. What's more, and this was pointed out in the editorial, the time course of the therapies varied. There were more standard antithrombotics used early, and more of the half-dose DOACs were recruited later in the study, which can bias the results because there's a learning curve with the Watchman procedure. Now, this study has major caveats. But I agree with my colleague, Dr. John Piccini, whom Steve Stiles quoted in a news story, that these are interesting and plausible findings. Half-dose DOACs may indeed be a better device-related thrombus prevention strategy than dual antiplatelet therapy. Of course, the best way to test that is in a true RCT, which is planned and going to be done. However, I cannot leave this topic without noting the obvious. If half-dose DOAC prevented device-related thrombus, reduced stroke and bleeding, perhaps an arm of any future trial that enrolls high bleeding risk patients should include a half-dose DOAC alone. Because, my friends, if this cocktail worked well with a foreign body in the left atrium, it's possible it could work even better alone. Never forget the history of Watchman. A, PROTECT AF did not pass FDA muster. B, PREVAIL did not meet non-inferiority in its first primary endpoint. C, procedural complications in the real world approach 5 to 10%. And D, 50,000 Watchman implants have been done in the U.S. and hardly any of these patients have been randomized in proper trials. This important study on half-dose DOACs in high-risk patients highlights the tragedy of tens of thousands of patients being exposed to a dubious procedure outside of clinical trials. If we had had the courage or incentive to randomize even a fraction of these 50,000 patients, we would know whether or not this invasive preventive strategy actually works. A final few brief comments on social media. The journal JAMA Network Open published a research letter, a survey on gender differences in physician use of social media. The first author was Nicole Wojtowicz, and I apologize for any mispronunciation. The survey generated about 580 responses, and 56% identified as women. Now, both men and women in this survey agreed that social media helped build their professional network, and both agreed that social media increased collaboration inside and outside their specialty, and both men and women agreed that social media improved their job satisfaction. But compared with men, women physicians were less likely to report that social media use expanded their research portfolio or resulted in a speaking engagement. Compared with men, women physicians were more likely to report using social media to build a support network, but were less likely to report using it to learn about research or clinical topics. The authors write and conclude the findings of this survey study suggest that social media use by women physicians may not improve gender equity. It may be the case that the same biases that lead to fewer opportunities for professional advancement for women persist in the online physician community, hindering women's professional advancement. Medscape Medical News covered the paper, and I agree with many of the comments made, specifically from Dr. Vineet Arora. She said she has mixed feelings about social media, that it was a necessity for one's career, but also that there is negativity and trolling, and I will add, downright nastiness. I'd recommend a read of the news article because the notion that not engaging at all seems like a bad idea. I mean, there's a ton of great information out there and oodles of opportunities for networking, no doubt. But the pandemic has changed my view of social media. Before 2019, I traveled all over the place giving lectures on the benefits of social media. Get online, I said. Speak your mind. Be rational, went my argument. Well, the polarization of the pandemic has shattered the notion that rational free thinking always works out well, especially on Twitter. Sure, I'll still use Twitter, but the ability to persuade on that platform approaches nil. One of the granddads of social media way back, Dr. V, or Brian Vartabeden, was correct when he wrote that you need a home base. Twitter and Instagram and Facebook, these are like outposts. A home base could be a blog, a website, a YouTube channel, a podcast. I recently started a Substack. Home bases are places where you can, in long form, tell the world about you. You can make logical arguments. Long-form writing, video, and conversation are the future, I think. And they seem much safer places for clinicians and scientists. As for Twitter, I agree with Drs. Arora and Shapiro, who were commented in the news article, that simply not responding to provocations is wise. Resist the urge, I tell myself often. And I favored muting over blocking. I want to close with this important message about social media and Twitter. It's not real. It's a small sample of vocal people who interact without personal involvement. Real life is in your clinic, at your hospital, at home with your spouse and family, at your kids' soccer games talking to friends, in the airport when you help an older person get their luggage in the overhead bin, or on the Appalachian Trail when you share a bag of trail mix or a few baby wipes with a colleague. Never forget that the algorithm of Facebook and Twitter is to provoke and to anger, because that leads to more engagement. The pandemic has reminded me of that, and I try to not fall prey to the algorithm. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember a couple things. One is that on the website, theheart.org, Medscape Cardiology, there's a partial transcript of this. And also, if you like this podcast, please take the time to give us a rating, write us a brief review. These comments go a long way to help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.